the leukemia, a treatment of leukemia in children was the first really chemotherapy given to anyone. It really came from the Second World War and mustard gas, and somebody in the 1950s discovered that if you gave some of these drugs, they give them to children first, their leukemia disappeared. Unfortunately, it always came back again. By the time I would have been treating, and we all did a bit of paediatric hematology, but very much into adults, you're talking about the late 80s and the 90s. And then we were giving intensive chemotherapy. If you got the people into remission, which we probably got about 60% of, there were all sorts of transplants and things like that. So we were curing some people, and that has consistently improved throughout the 30 years of my career. The drugs have changed a bit, particularly the area I'm interested in acute myeloid leukemia, where there were few new drugs until recently, and now there's lots of other options. Transplant comes in, and we'll not do a transplant talk, but there's issues of when you do or don't transplant, and it's curative in some people. The children, of course, is out of this world different, because the vast majority of the children who have most commonly have a different subtype, acute lymphoblastic leukemia, the vast majority of them are cured, but they're not all, and there's lots of things to back that up. And of course, that's always the tragedy, the children that don't do well, and that's the ones people remember, because particularly children, although I've always dealt with young adults and it's the same age. The group that of the leukemias that we're really only starting to make any difference to now are the elderly group. And as I now fall into the elderly group, if you look at the figures, they're really quite poor. Very recently, there have been some new options coming. The problem with the drugs that we give to the younger people is that older people can't stand the treatment, and there are new treatments coming in, and I think there will be a lot more on that over the next few years. I'm partially retired, so I've stopped treating acute leukemics for the last 2 years, just 2 years, and I mean it has changed further. It's now very molecularly directed, so that we now know so much more about the genes and what genes have gone wrong, and then have treatments to target specific gene lesions. Whereas I would have been treating all that group of patients with that drug, we're now getting more and more information and breaking it down into smaller and smaller groups. So there's lots has been learned, but there's lots more to be learned. The other areas that I'm involved in, and the one I think you perhaps want to think about the most, is chronic myeloid leukemia. So chronic myeloid leukemia is one of the myeloproliferative neoplasms, but it's slightly different. It is a chronic type of leukemia with a very specific defect in the cancer cells. And in 1999, the first patients in the world got an oral treatment for that. And I have a photograph of the first patient that we got a bottle of this treatment for in Northern Ireland. I think it was beginning of 2000 we got it. And very quickly that oral treatment became available for all. And there are now 6 licensed tyrosine kinase inhibitors. The oral treatment was a tyrosine kinase inhibitor. So you've gone from one treatment which you gave to people, they went to remission and they stayed in remission, to 6 different options, obviously first line, second line, third line. All of them have side effects, but they're all oral. And we're now at the stage where if people get a very good response, we're taking them off treatment, and a large proportion of our patients are off treatment and staying off treatment. We can have a philosophical conversation as to whether that is cure or not, but I mean it's certainly long-term treatment-free remission. So we've gone from in 2000, where if you had a diagnosis of chronic myeloid leukemia, if you weren't eligible to have a bone marrow transplant or something like that, your life expectancy was about 5.5 years, to a situation now where if you're diagnosed with chronic myeloid leukemia today, you'll have to take the tablets I give you, but you have a normal life expectancy. So that is probably the best advance, apart from perhaps the children leukemias, there's been in haematology oncology, but it is a remarkable change in one clinician's lifetime.